I'm going to go ahead to directly introduce the next speaker, Professor Stefano Cappa. Professor Cappa actually has been in Hong Kong several times, and we met each other. And so Professor Cappa actually graduate in medicine and specialized in neurology in University of Milan. And he has spent a period of time in study in Boston, MIT, and Medical Research Council cyclotron unit of the Hammersmith Hospital in London, and even Max Planck Institute for Cognitive Neuroscience in Leipzig. And he became full professor of cognitive neuroscience at the University of Vita Salute San Raffaele in Milan, and director of the unit of neurorehabilitations of the San Raffaele Toro. Since year 2013, professor of neurology at the IUSS of Pavia, and also director of the Feta Benefatila Brazil Massacre, and also the Mondino Foundation's Institute of Neurology. So without further ado, we are going to play the pre-recorded lecture from Professor Cappa.
Hello, my name is Stefano Cappa, and I'm going to discuss with you some aspects of prevention related to a specific situation, that is subjects at risk for Alzheimer's dementia. Let me share my slides with you. Okay. These are my disclosures. When we talk about prevention of Alzheimer's disease, we can focus on different aspects: primary prevention, secondary prevention, and tertiary prevention. My talk is going to be focused on the second aspect. Of course, this is a choice which is related to practical. Basically, this is what you are involved when you are considering the issue of Alzheimer's prevention at the level of the individual subjects. You are going to hear a lot during the talks of this wonderful meeting about aspects related to primary prevention. And of course, primary prevention study for the background of any prevention effort. Also in the secondary and tertiary stage. But what I'm going to talk about is this level in which you have a subject who has already some features of the disease, as indicated, for example, by biomarkers, which are already associated with some clinical expression, or even in a symptomatic level. And what you want to do, what you're attempting to do, is autism, maybe too ambitious in this case, but you are going to, you want to try to modify the disease progression. Let me try to focus on this further. Primary prevention is, as I said, providing the whole background, this construct of prevention of neurodegenerative disorders. And of course, the evidence for primary prevention factor comes from epidemiological studies. We already have some hints that primary prevention might be already in place. I'm referring, for example, to the epidemiological studies indicating a decline in dementia prevalence according to the decade of birth of subjects, which suggests that a factor related to social situation or to healthcare system are already impacting on the likelihood to develop dementia in the different age cohorts. This is a very well-known example of this kind of studies providing demonstration, well, suggesting that several of the factors which have been indicated by as prevention or risk factor in prevention studies are playing a major role in the possibility to develop dementia during your lifetime. This is a sort of fundamental reference. This is the Lancet Commission report led by Professor Livingston, which a recent revision has appeared, which indicates the multiple risk and protection factors which have been associated to the risk of developing dementia during your lifetime, subdivided according to the life period in which these factors are mainly supposed to act. That is early life, this is the case of education. Midlife, this is the case, for example, of health-related vascular risk factors such as hypertension or obesity, and later life, such as social isolation or physical activity. Major result from this work, which has had a huge impact also at the level of general lay knowledge, is that if you calculate the possible impact of a ideal management of these risk and protection factors, theoretically, you could reduce the prevalence of dementia by a factor of 40, which of course is extremely impressive in terms of public health. And to this, I would like to add as another reading suggestion this excellent systematic review and meta-analysis, which provides a really careful and exhaustive description of the prospective studies and the controlled trials which have been taking place, focusing on these different factors. So, from this kind of evidence, you can derive a simplified picture such as this one, in which you have intervening factors, which can be risk factors or protection factors, which modulate the pathway between factors which are not modifiable, such as the genetic risk, and the final outcome, that is dementia. And you see them here organized according to the same perspective as in the Lancet Commission paper, is according to the age in which their main effect is supposed to take place. And this is going to work as a sort of background to the specific application I'm going to discuss with you. I must say in the first place that there is already evidence that intervention focused not on each of these single factors, but on a combination of these risk and protection factors may have an impact at the population level on the prevention of dementia. The evidence is coming from the finger study originally developed in Europe, Pelto, and now a huge endeavor involving many parts of the globe. Finger Word Initiative, which is based on the original observation that a multi-domain lifestyle intervention applied on an elderly population of subjects at risk. We are going to go back to this definition of risk because it can be used, of course, in different ways, can have a protective value in terms of successful aging, protecting brain health and promoting overall health and function. So this is a sort of general reference at the population level. What I try to do in the next part of my talk is to try to apply this sort of perspective at the level of the individual subject. This is the level which is clinically relevant. If you are involved in the diagnosis and care of patients with neurodegenerative disorders, and in particular of cognitive decline, this is becoming a very important part of clinical practice. That is, which kind of active intervention to propose in at-risk subjects. In this case, we are talking about one specific aspect of risk, that is the risk of developing Alzheimer's dementia. Why I'm focusing on this? Of course, because this is a very common condition, and because this is a situation in which the role of prevention is just starting to be appreciated at the level of clinical management. Okay, let me show you this slide, which is, when you show it, you usually excuse yourself because it has been shown so frequently. Such a whole generation of slides showing this kind of curves. I think that everybody is familiar with this so-called dynamic model of Alzheimer's disease and Alzheimer's dementia, which fundamentally underlines that dementia is the very late and final stage of a very long pathological journey, people like to call it nowadays, a journey which begins decades before its clinical expression, which, by the way, is not defined by dementia, but it's defined by a whole range of situations ranging from minimal subjective symptoms to objective cognitive impairment up to the final stage, dementia. Preceding this clinical stage, indicated here by the green line, you have several different steps leading to the final clinical consequence. The process is considered to start with beta amyloid deposition in plaques, which, according to the most well-known and widely accepted model, plays a fundamental role in starting the tau, the phosphorylation and deposition progress, which ultimately, in combination, lead, after the spreading of the pathology, to neurodegeneration, that is on a direct impact on neural function and structure, leading finally, as a consequence, function and structure derangement, to the appearance of clinical symptoms. This time course of Alzheimer's disease has been recognized and popularized in the last decade by the availability of markers allowing the in vivo identification of the preclinical stages, or the measurements of these stages in the patients where the consequences have been already expressed as clinical complaints and objective deficits. The biomarkers of physiopathology, that is biomarkers of amyloid deposition, biomarkers of tau pathology, and biomarkers of neurodegeneration. The combination of these different aspects, biomarkers and clinical expression, lead to the individuation of a very complex array of conditions, which has led to complex terminology and also to several discussions about the meaning in terms of prediction value of these numerous labels which are going around nowadays. Recently, the International Working Group, and it was a pleasure for me to be involved in this process, has attempted to provide a description and a categorization of this complex array of conditions, which include clinical condition and non-clinical condition in asymptomatic subjects. What all these different conditions share is that they can be considered as possible steps in the Alzheimer's disease progression story, and to be associated with different levels of risk of progression to the most dreaded conclusion of the journey, that is dementia. Let's distinguish in the first place clinical condition and conditions which are characterized by the fact that the subject is not symptomatic. Are these clinical conditions by pure lexical meaning? They are not. However, they are now becoming, in some sense, clinical condition as people decide to ask information about their biomarker status, still infrequent but happening, or subjects are included in research studies which include the assessment of biomarkers in asymptomatic subjects. Let me go through this list. Let's start from the clinical side of the coin. On the clinical side of the coin, you have a number of conditions which are characterized clinically. Subjective cognitive complaint. 3 of these conditions are just clinical. That is, they don't include biomarkers. So, by definition, in the absence of biomarkers, they can be a manifestation of a process which might lead to Alzheimer's disease. But in the absence of biomarkers, they can also be attributed to many other possible conditions. So from this point of view, the first 3 items on the list are characterized by a risk which is clearly inferior to conditions in which you have the same manifestation associated with the positivity of Alzheimer's disease biomarker. So you have, starting from the condition which is in which the risk is clearly undetermined in the absence of biomarker status, complaints of cognitive decline. Of course, here the differential diagnosis is with the physiological aging process or with other conditions such as depression. This is a diagnosis which is now made frequently on the basis of criteria, which by definition include a normal performance on cognitive testing. Then you have the condition of mild cognitive impairment. Between subjective complaints and mild cognitive complaints, you might include a condition which is called by some authors as a pre-mild cognitive impairment, which can be defined in different ways. However, it shares the different definitions share the observation of minimal objective cognitive decline, or a discrepancy between clinical impression and the results of the formal cognitive examination. So in this sort of stage represents an intermediate stage with the most well-known entity, which is mild cognitive impairment, in which there are subjective complaint and there is objective impairment, which, however, is not so severe to interfere in a significant way with activities of living, and those cannot be defined as dementia. These are conditions which are defined on a purely clinical basis. Then you have in red here the most relevant condition nowadays, at least at the research level, that is prodromal AD, a condition in which you have mild cognitive impairment, that is the presence of objective cognitive impairment as defined by neuropsychological tests, ideally neuropsychological tests which are specific for Alzheimer's dementia compared to other conditions which can be associated with the objective decline, and positivity of biomarkers. This is now considered on the basis of accumulating evidence from large-scale studies as the condition at highest risk for progression to Alzheimer's dementia. And then you have a full array of conditions in which the subject is asymptomatic. However, there is evidence of a risk of progression to, in this case, rather the progression of entering in the Alzheimer's disease pathway because of the positivity of biomarker. There is also another situation, which is, however, very different, very rare, in which even if you are asymptomatic, you carry a very high risk, which is, of course, if you are a carrier of a pathogenetic autosomal mutation, dominant mutation. These are highly controversial situations from the point of view of the quantification of the risk. And they include the condition in which there is a positivity of both physiopathology biomarker, that is both amyloid and tau, presence of tau deposition going beyond the entorhinal cortex, and the presence of ApoE homozygosity, which is a major genetic risk factor, leaving aside the pathogenic mutations. These are conditions which are considered to be associated with high risk. There are, however, other situations which are now becoming relatively frequent as people having biomarker assessment. As asymptomatic people are having biomarkers assessment, that is a positivity of amyloid without tau positivity, or a positivity of tau without. These are all situations in which the risk at the moment is undefined. In the coming years, we will know much more about this condition. I just wanted to, however, to underline a general point that all the conditions in this list can lead to Alzheimer's dementia, and the risk is different, as we've seen among, for example, symptomatic and asymptomatic subjects, but do not necessarily lead to dementia. I think this is a very important point from the point of view of prevention. Take, for example, as I said, prodromal AD, that is mild cognitive impairment associated with biomarker positivity, is a high risk condition, and we know it from longitudinal studies. But for example, subjective cognitive complaints are not, in the sense that they clearly are high risk. As you can see, for example, there are many studies nowadays, and several others are coming out. You have a good third of subjects which are showing progression over 7 years of follow-up. However, you have a sizable proportion of subjects who are not going to progress. And actually, in this study, several factors have been identified as predictor of progression in this population, such as years of education. This leads immediately to the issue of secondary prevention factor and concrete research, or the presence of stroke history, etc. For the asymptomatic subject, that is the list of conditions in which the subject has no clinical symptoms but has biomarker positivity, we are just getting positive knowledge from longitudinal studies following these subjects for a long period of time. And in this table, I'm reporting the results of 2 studies and of the pooled data paper, in which you see that being amyloid positive is associated with the increased risk in comparison to the control population. However, a large proportion of the subjects who are amyloid positive do not progress over long follow-up. The studies are still relatively limited in size. The number will increase in coming years. As you can see, there is a huge variability in this pooled data analysis. However, it's clear that not everybody, at least what we can say is that not everybody, even in the highest level risk population, that is prodromal AD, is going to progress to dementia over a period of several years. And I think this is a crucial point for at the clinical level for secondary prevention. When we see a patient who is in any of the symptomatic stages, and when you consider, and this happens mainly, of course, by definition, at the level of research studies, but this might change in the future. We see an asymptomatic subject which belongs to one of these different classes of biomarker positivity. You have to consider the possibility of a management plan, which is basically a plan for secondary prevention. And this is what I'm going to discuss with you. I mean, there are no defined answers, but on the basis of what we know now, there are the possibilities are clearly for a multimodal intervention, which in this case includes several components. And I'm going to discuss the limited evidence we have for secondary prevention, taking into account very briefly the role of pharmacological therapies, discussing a little bit more the role of what we can call a resilience enhancement and of neuromodulation. Okay, pharmacological therapy is, of course, a hot topic these days. However, it's from within this perspective of secondary prevention, it's clear that possibility to have access to a disease-modifying drug represent a major, can be considered as a major secondary prevention factor. The drug is effective, of course. I'm not going to discuss this in any detail, but as you know, the available evidence at the moment points to a possible role of beta clearance as a possible protective factor for progression. And what I would like to stress here, that in any case, it makes sense to combine this treatment to some other aspects of secondary prevention. And for this, I would like to make reference to the concept of cognitive reserve. As you know, there's going to be a talk by Stern in this meeting, which is, I consider him as the sort of father of the cognitive reserve concept. So I would just like to stress some aspects which are relevant for this secondary prevention perspective. The concept of cognitive reserve was born on the basis of mostly of pathological observation, that is of a discrepancy between pathology load and the clinical consequence. So we go back many years before the possibility to measure the biomarker to this concept of a relationship between the pathological process and its functional consequences. Classic, there was this paper by Blessed, Thompson, and Roth. This was this observation of discrepancy were sort of violating this dogma of clinical anatomical correlation, which had been leading clinical medicine since the time of Charcot, one of the major developers of the clinical anatomical correlation. And its modern implementation, I would say, starts from this study of Jakob Stern, in which using the method which was available at the time, that is two-dimensional regional blood flow measurements, he measured in vivo the match between a proxy of pathology, that is in this case cerebral blood flow related to regional brain function, and a proxy of cognitive reserve. Cognitive reserve is something which cannot measure directly. However, education can be considered as one proxy of this factor, and as a modulator of the third aspect, which is clinical severity. And basically what he found in this study is that subjects with a higher education had a higher degree of hyperperfusion, indicating a higher degree of pathology in comparison to matched subjects from the point of view of clinical severity who had a lower education. This introduced basically the concept of cognitive reserve. If you have low reserve, a mild degree of pathology is associated with a severe clinical picture, while if you have high education, this is a proxy of a higher cognitive reserve, so you have a higher degree of functioning, even if the pathology is at the same degree as of extension as the low education group. This has a secondary consequence that at a certain point, the decline of subject with a higher education is steeper. When you reach the limit of this compensation provided by the reserve, then the severity drops in a very dramatic way. This was done by Stern and colleagues in 1992, Years later, we were able to replicate this finding using more recent imaging technique, that is positive emission tomography with the fluorodeoxyglucose. And we found in a study which was based on a similar, totally similar model, that is subjects matched for clinical severity, having different levels of education. We also look at the effect of occupational attainment, another possible proxy of this cognitive reserve concept. And we found that we had exactly the same finding a negative relationship between the level of education and the severity of hypometabolism in areas which are typical areas for Alzheimer's disease, that is in the temporal parietal cortex and in the precuneus. This was true also in the case of education, of occupation, and was true also in the case of subjects who were in the MCI stage, that is in a stage, well, at that time, not a long time ago, but things have been changing fast in this area. We didn't have a definition of the subject as prodromal Alzheimer's disease. These were just clinically defined MCI subject, and we found the same kind of relationship, both in the case of education and occupation. So many additional studies are available, and the concept has been extraordinarily developing after this initial observation. I must say mostly by the merit of the work of Professor Stern, but also of several other groups which have contributed to the idea that cognitive reserve mediates this relationship between pathology and clinical manifestation. Education is one of the proxies. Verbal IQ might be, especially in some study by Stern's group, a better estimate of cognitive reserve. What I would like to underline is the definition, definition of cognitive reserve developed by this working group, which has with great care attempted to provide clear definition of the multiple different labels which have been applied to the concept of modulating factors between pathology and clinical manifestation. Cognitive reserve is an active process. And this is what is really interesting from the point of view we are taking now. That is the point of view of secondary prevention. It can be defined at this cognitive level, but it can also be defined at the brain level. This leads to some sort of confusion between cognitive reserve and brain reserve, which, however, if you read these and other papers by the same group, this can be clearly distinguished. It's a dynamic cognitive and the underlying functional brain processes coping with brain changes and damage. From this point of view, it's an active response which is responsible for resilience to the Alzheimer's pathological process, which we have been discussing in some detail. And from this point of view, it can thus be differentiated to resistance to it, which of course is clearly heavily dependent on clearance mechanism, but also in initial differences in the structure and function of the brain and then maintenance. So this is different from the brain substrate of the active adaptation process leading to resilience. This is something you already have. This is not something that you can gain actively. And I think this is a very important point from the practical standpoints of intervention study. If you go back to the diagram of risk and protection factor, you can have a look at them from different perspectives. What you see here are those factors which are amenable to intervention for risk reduction. This is what you want to do in the case of secondary prevention. You have someone who has a risk, and you want to reduce and modify the risk. And of course, there are many things you can do, but this, as you should remember, this list is derived from an epidemiological study. And what we really need in order to use this list as a sort of guide for our prescription, we really need the studies which indicate whether intervention studies on these factors are useful from the point of view of the prevention in that specific subject. That is, physical activity, just to take an example, of course, is measured in epidemiological studies on the basis of lifelong physical activity. The same applies to diet. What you want to know in your individual, who can be a mild cognitive impairment subjects, a subject with prodromal AD, if you have biomarkers, an asymptomatic subject with amyloid positivity engaged in a clinical trial. What you want to do is, what you want to know is whether changing the physical activity or the diet is going to be useful as a protective factor in the subject. And of course, some of these factors are probably mostly related to the status of the brain. Consider, for example, all the factors related to vascular risk factors, or all those aspects which might be related to a lifelong exposure, such as diet or physical activity. Others, however, might be more prone to dynamic changes because of intervention. Thinking about, for example, cognitive stimulation or social engagement, or even depression and correction of hearing loss. What we know about the preventive, protection, the secondary preventive effect of these factors after intervention in subjects at risk? Not so much. For example, in the case of diet, we have unequivocal evidence that diet plays a role in cognition. These are few studies we have been leading in northern Italy, in which Mediterranean diet is not as, let's say, rooted culturally as in southern Italy. Things have been changing a lot in the last few years. But we are dealing with the elderly population in an area which is not famous from Mediterranean diet, in Lombardy. We have been studying the cognitive status of the subject, for example, asking for a dietary intervention because of medical advice. That is, these are not subjects coming for cognitive complaints, but subjects who are coming to a dietary advice resource because their doctor has advised some change in diet because of health factors, the majority obesity. All these subjects had cognitive screening with the mini-mental, and we found a significant impact of of several dietary factors on the mini-mental scores. That is an impact of the Mediterranean pattern, which, as I said, was not present necessarily in all the subjects, but was only the proportion of them, of a moderate positive effect on moderate consumption of wine, a positive effect of the consumption of nuts. We have been also leading an intervention studies, which I don't have results, in a different sample, a sample of frail elderly subjects, defined according to the standard Field definition of frailty. And these are the baseline data. This was also conducted in the same geographical area of northern Italy. And we found some correlation of neuropsychological performance with nutritional assessments, in particular on executive attentional tests such as the brain-making test. And what we found by this structural equation modeling is that there was a direct effect of nutrition as measured by the Mediterranean score and the mini nutritional assessment on attentional performance, not mediated by anthropometric and physical activity scores. The same did not apply for the other tests in which there was a correlation with the nutritional performance, with the nutritional indexes, that is verbal fluency and memory. However, if you look at the available evidence on the impact of dietary intervention rather than of lifelong dietary habits, I'm just mentioning some meta-analysis for your interest. The results are extremely heterogeneous, and mostly, I'm afraid, I'm sorry to say, on the negative side, with the exception of the studies which I already mentioned, in which dietary intervention was combined on in a multimodal management plan, which, however, as we have seen, was not targeting a specific at-risk population, but the general population with typically vascular, increased vascular risk. The same applies to physical activity. There is a lot of evidence for the protective effect of physical activity, but very little uncontroversial evidence for the impact of intervention studies in specific population at risk for dementia and or for Alzheimer's disease. Cognitive activity is another area in which the results are quite heterogeneous. There are going to be talks during this session, during this meeting, about several types of cognitive intervention. What we can say is that the meta-analysis do not provide strong support for example, computerized training. And this is interesting because actually you can get some results in terms of improvement of cognitive tests performance. This is a study we recently performed on a relatively large sample using a computerized intervention, and we found that the computerized treatment was actually effective in improving the performance of specific tests, such as the free and cue selective reminding, in comparison to a conventional supportive treatment, and that the effect was actually present also in the case of at distance administration rather than face-to-face administration. However, these results are not supported by results indicating that there is a real protective effect in terms of progression to dementia. Several other factors can be considered and need to be considered because it's quite likely that the results in terms of specific intervention studies might be in line with the results of the finger study. That is that only a combination and possibly an individually tailored prevention programs is effective in subject at risk for Alzheimer's disease. Certainly, I would include in the list social engagement, for which there is a strong support from epidemiological evidence, receptor functions such as hearing, but also vision, and sleep. This is another area in which there is considerable evidence that it might have an impact in terms of cognitive reserve and also brain reserve. I would like finally to mention neuromodulation. Neuromodulation is a possible third approach which can be employed at the individual level. What is the evidence for this? We were among the first to show some effect of neuromodulation in Alzheimer's disease in terms of test results, again. A series of studies done a few years ago in which we were able to show, for example, that TMS as applied to the left dorsolateral prefrontal cortex had an impact on the naming ability in comparison to a control sham condition. The literature, I don't have the time to go into the extensive literature which has developed in the last decade, but I would like to underline that the potential of use of neuromodulation is probably much larger than what we thought originally in terms of stimulation effect. There is some evidence pointing to a possible direct effect on brain reserve in terms of protein clearance and impact on pathogenetic factor. There is a very interesting trend also in this case for a tailor-made precision medicine approach to neurostimulation based on targeting of specific networks on the basis of connectivity measures. And there are also very interesting studies about the possible impact of specific oscillatory synchronization in order to improve cognition by means of a mechanism which could be defined according to the line of cognitive research, that is dynamic changes supporting the networks involved in cognitive function. To summarize, the evidence for primary prevention effect has indicated the most promising candidates for intervention studies, but the number of quality studies in prodromal and preclinical remains limited. It is clear that intervention aiming at increasing brain resilience via changes in cognitive reserve must be considered as an important additional option, also in the case of pharmacological treatments for the secondary prevention of AD. And I would say that it's now clear that there is the need for large-scale longitudinal studies of multimodal intervention to assess the impact on brain and cognitive outcome measures in subjects at risk for Alzheimer's dementia. Thank you very much for your attention.
Hello, Brandon.
Ciao, Stefano. The chair of the session is Raymond. I'm just waiting for him to come back in. But thank you so much for a brilliant presentation and very interesting research findings from Northern Italy. We're interested, of course, in translating this work into the Greater Bay Area in Hong Kong and around Hong Kong. And I'm wondering a little bit about the recommendations you have for further clinical work in terms of the research environment. That is to say, we have a limitation in how far we can examine randomized control studies. And I think that this would be something to work on. Would you give us some technical advice on how it's best to go about doing that in such a linguistic and culturally diverse environment as the Greater Bay Area?
Well, I don't think it's a problem just for the Bay Area. I think it's clear that there has been a huge there is now a huge effort and a huge engagement at the level of public health that is on large-scale studies such as the finger studies. And of course, this is clearly a very important endeavor. On the other hand, what I was trying to focus was on the level of more on the level of the individual management, which of course needs to be supported according to a precision medicine approach on a randomized clinical trial. Of course, the limitation in this case is that it's much more expensive. I mean, the idea of the population of the finger study is to engage huge population with a minimal assessment, well, a sort of basic assessment, that is the definition of subject at risk. If you want to look, what I'm interested into, but I mean, this is clearly a general issue. What I'm interested into is having an idea whether when I see an individual patient with I can define the risk profile and then plan a treatment which is evidence-based. And as I try to convey in my talk, people tend to translate directly the results from epidemiological studies to the clinical practice. There is evidence that physical exercise is good. What I would like to know, and this could be done on the basis of a small but extremely well-conceived clinical trial, is whether a change, a realistic change, possibly individualized on the basis of the physical status, but according to some formal program, could be translated in a high-quality clinical trial, which has as outcome precise objective measures. There are some places in which this kind of approach is taking place. Nowhere in Italy for the moment, but this is what I'm trying to propose. There is excellent work being done in this area, for example, in Germany. Emra Dützel, whom you might know in Magdeburg, is running very interesting study of this kind on physical exercise, in which the subjects are extremely well characterized from the point of view of the biomarker status, etc., and they are engaged in a clinical trial which has very, very hard outcome measures. For example, with physical exercise, leaving aside the fact that physical exercise is good for a number of reasons, there is also the possibility coming from preclinical studies that there is a direct effect on blood flow, possibly mediated by angiogenesis. So in this case, here's already published a few papers on this. You can have measures, a measure of hippocampal blood flow and vascularization. So, as usual, there's this tension between large-scale studies, including relatively simple measures, and the small-scale but highly, very well-structured studies, which might provide more precise outcome measures for the large-scale studies. This is my personal position. Of course, these are two different. These two approaches are on a different scale. But I think that, for example, in the Bay Area, in which you have a very well circumscribed population, in which you know a lot about exposures, etc. I mean, this would be an ideal area to run specific studies with very clear definition of the outcomes you want to check. Of course, the hardest outcome remains, for example, in population at risk, remains progression to Alzheimer's disease, but this requires years. We are seeing it, for example, with these interesting asymptomatic studies. You have seen the summary. If you collect a sample of highly characterized asymptomatic individuals, Of course, you can get the hard outcome of progression, but this is going to happen in 20 years, and probably many of the subjects won't be there because of the natural attrition. So you need to introduce other outcome measures, which however, are possibly relevant for the risk profiling. I think it's a very interesting moment from this point of view, because I mentioned this in the talk, the fact that now there is this very controversial application by the FDA of aducanumab might have an impact. This is the reason why I'm in the group of people who are not so negative about, but tend to be positive, because this might be, if this is taken as an opportunity to run studies which probably might at the end indicate us which is the best population to target, which is the population which makes sense to target. Because going to the story, for example, of a dietary intervention, I mentioned that we are running these studies with a lot of difficulties in this area. Well, you know the area, Brendan, because you have been visiting us several places. This is not a really Mediterranean culture, so people eat a lot of fatty food, animal food, etc. And I mean, you take someone from this area who's been eating like that, who's 75 and he's been eating like that for all his life, and you try to change his or her diet. This is tough. The compliance is low, I must say, very low. And we are not sure whether this is really effective, because this is not a lifelong effect. This is going to be 6 months.
Yes.
So I would like to know more about this.
Thank you. That's incredibly useful and a great recommendation, extremely concrete, and something with the resources that we have in the Greater Bay Area, which are not small, is certainly possible. Now I see Raymond is back. So Raymond, could you please?
Hi, Raymond.
Hi. Sorry.
Very nice to see you.
Yes, very nice to see you, actually. Yes, it's very good to listen to the concept as a primary, secondary, and tertiary. And so I saw your MRI slide on the education. How do you do this?
You mean the cognitive reserve studies?
Yes.
This was just measured as in the. It was exactly a replica of the original Stern study, measured as years of formal education. What we had more than that was occupational attainment, which is another weak factor which might be associated with cognitive reserve. I think you're going to have a talk by Jakob Stern today or tomorrow.
I see.
This is going to be exciting, because I've been reading his latest work, and I'm really fascinated by this idea that we can really have some measures which are more proximal to the measure. If you consider there has been a lot of confusion in the literature about cognitive reserve and brain reserve, because of course, as cognitive neuroscientist, I was among those who said, come on, cognitive reserve at the end is something which is the manifestation of a brain process. But this is absolutely clear now in the definition of cognitive reserve as a dynamic reorganization, which of course has a brain counterpart. So Jakob is doing some very nice work in trying to measure changes in cognitivity, which might actually be more directly related to this reorganization process. And I think this is a very interesting way to go. I mean, if you can go from these measures, which are really very distal to any process which is taking place in the brain, such as what you did when you were in a younger, or in what this might have impacted on your possibility to reorganize towards some more direct measure of reorganization. The point is that, and this is a point which relates to all of the MR literature, I should say, is that it's not really clear what is the metrics of this reorganization, because my reading of the literature, sometimes you find something which change, it's increasing connectivity, decreasing connectivity, and then you have a post hoc explanation for both sides of the coin. It's very important to have an a priori prediction, but probably we are learning more about this. I hope so.
Okay, so we have some questions from the audience, and I read out the questions as, first question is, biomarkers for AD are advancing very quickly, but there are lots of asymptomatic cases. I think first talks from Carol also mentioned about this. And when should pharmacological treatment be introduced in the course of the disease? Should biomarker be employed for prevention? And so biomarker be employed for prevention at this point at individual levels?
Well, that's a big question, of course. Okay, we are discussing. Everybody is discussing this at this moment. What happened I can tell you something which happened in Italy from the point of view of it's not directly related to an answer, which of course I cannot provide an answer. One thing which happened in Italy is that the Italian Drug Agency, which is usually not so fast in the decision, a few years ago decided to support a study in order to help the definition of the best combination of biomarkers which could predict progression. Of course, this is in mild cognitive impairment, so we are not talking about preclinical. So they paid for this study, which is actually not a very exciting scientific study, because it's just a study of the standard biomarkers as they are done in research centers. So it's CSF, hippocampal volumetry on MR, and ApoE. It's not and neuropsychology, of course, and EEG. So it's a sort of low-cost study. No amyloid PET, because that was too expensive, and they supported it in order to be able, at the end of the follow-up, which is going to finish in a couple of years, to advise about what is the best combination of biomarkers which could predict progression, and from this derive which is the population which should receive the drug if any drugs became available. So I think something similar should happen. I mean, if and when we are authorized to use the drug in clinical practice for the asymptomatic subjects. I mean, that was exactly the point of the paper I cited, recently published in Lancet, trying to define, to advocate for an objective definition of the risk profile, which could clearly has a crucial impact for decision about drug administration if the drug becomes available. This is happening. Several studies are going to. I think we are going to have an answer from the point of view of the risk profile. Of course, this does not directly map to the decision about giving a drug, because of course we should have the evidence that the drug is effective in that group. But I think this is the group which is most likely to give a response, I believe. Because let's remember that the studies on which the FDA decision was made included MCI and earlier these subjects.
Yeah, thank you. So the second question is it possible that cognitive reserve can mask symptoms that, if treated earlier, would result in better mental health outcomes?
Yes, I think so. Probably this is the case of that situation I mentioned and didn't discuss because we don't know very much about it. That is people who are not symptomatic, but show some objective deficit. This, of course, by definition, comes out of research studies, because if you are not symptomatic, you don't go to see a doctor. So these are subjects which are seen because they participate in a study. By the way, there is a very interesting finding by Bruno Dubois group, which is very interesting from the neuropsychological standpoint, that what they found in a symptomatic population is that in symptomatic or subjective complaint population is that the effects are not so strong, so they are going to try to replicate it in another study. But those subjects who were actually mildly impaired but did not complain apparently had a worse prognosis than those who were complaining but did not have any objective impairment. So this is related to the issue possibly of reserve, but on the other hand of anosognosia. That's the reason why I think it's particularly interesting from the neuropsychological standpoint, because I mean, consciousness in a very broad sense is not usually considered among the features of, which can be affected by the neurodegeneration. Depends on the meaning you attribute to consciousness, because of course if it's related to arousal, one aspect, it's related to the content of consciousness. Clearly there is a reduction. If you take a sort of quantitative vision of consciousness, clearly there is some decrease from this point of view. And I wonder whether this might not be related to what the neuropsychology usually called anosognosia or the cognitive deficits. I think there are a lot of interesting things to investigate from this point of view.
I see. Thank you. So the last questions here, also one question is, how could screening for MCI be improved in primary health setting? I think everyone wanted to answer these questions, know the answer of these questions. And are there potential reversible factors that are lacking an earlier diagnosis?
Okay, this is clearly very highly culture and health system specific, because well, I can tell you what we are trying to do here in Italy, which clearly applies to many situations with the National Health Service, in which the first interface is the general practitioner. So there is a huge effort to change the culture at the level of the general practitioner, because in general, the situation used to be that the general practitioner neglected cognitive complaint elderly people, considering this as part of the aging process, or taking the position, well, there is nothing to do, so why bother? Now this is changing a lot, because also of the generational change in the general practitioners, which tend to be the young general practitioners, to be more highly motivated. So I think their role in the detection of mild cognitive impairment is crucial, and of course it should be very practical. I consider the actual limitation. I mean, asking the general practitioner to do a very complex evaluation is not feasible. But at the end, introducing some very simple screening tool, which by the way, should not require more than talking 10 minutes with the patients, has a substantial effect if this leads to a higher level of referral to the network of specialist centers. So I think that most of the work in that area should be done at the level of the general practitioner. And by the way, this applies also to the second part of the question. I mean, we were discussing with Brendan about running high quality clinical trials on prevention factors. However, what happens in practice is that you give a list of suggestions which is very, very simple. This is simple. And I mean, nothing wrong about giving this list. Oh, sorry. This is something which should be done by the general practitioner rather than by the specialist. So I think both aspects rely crucially on paying attention to the entrance in the medical care system.
So I actually also have a questions. For examples, in Professor Livinden's talks is about educations. She emphasized the first 20 years, right, in your oral study. So can you use education to in the late stage, for example, now we emphasize of the whole life continue educations and to learn something new, right? Can we learn something new to compensate the loss of education in the early days?
I think that this is a crucial aspect, that I think that motivation plays a central role. I think you already had the talk about the bilingualism and learning a second language as a sort of cognitive stimulation approach. I think this is excellent, but of course, this again should be individually tailored. I mean, when you talk about education, this really neighbors a lot with, I'm sorry, the neighbors is very close to cognitive rehabilitation, because you can call this as one approach to cognitive stimulation, cognitive rehabilitation. I think it's very important, and this is a very practical thing, to try to select an educational or cognitive stimulation approach which is relevant and of interest to the subject. If I ask to learn a second language to someone, if I advise to learn a second language to someone who's not interested because he never moves from his village, come on, this is a waste of time. But there might be some other educational aspect which is motivated and is going to be followed. It's not good to take as examples, as we do often in our studies, what we call in Italy third age university. Most cities have this sort of it's a sort of a institution which is supported by some public money, but also by volunteers, etc., which provides courses. I mean, only highly motivated and educated people go there. The problem should be related to the request and the needs of the actual population, of the actual subject you see. But I'm convinced that this is helpful, because there is the educational aspect, the cognitive stimulation aspect, and the social aspect, of course.
Wonderful, thank you. I think, Brandon, do you have anything to add?
I do indeed. Thank you very much, Professor Chang, for chairing the session and handling our questions, and again to our speakers and yourself included, particularly to Professor Cappa for stepping in and giving us such a great way forward. I think just a little bit of context to finish. Of course, we are located in a faculty of education, and one of the lessons I learned from making that step into the faculty of education late in my career, now retiring, is that education really is a better platform for us to think about cognitive reserve. In terms of Hong Kong, for example, education is very highly valued, and indeed Hong Kong students perform better than anywhere else in the world on standardized tests such as PISA and so on. So we know we have a human resource in Hong Kong that is
Absolutely.
growing, cumulative, and therefore should be invested in a way that will prevent the onset, hopefully in several decades from now, the development of dementia. So I think we should highlight this because education in Hong Kong is seen as a value and a virtue, but also within the Faculty of Education at the University of Hong Kong, where incidentally we are fairly highly ranked. We do a good job in training teachers, enthusing students, and making sure the quality of education throughout Hong Kong is very high. And by extension, I think we need to emphasize this point throughout the Greater Bay Area, where standards are somewhat variable, and yet we do offer a beacon of hope in the Faculty of Education for promoting the value in terms of cognitive reserve and ergo neural maintenance moving forward. So I'm extremely grateful to Professor Cappa for stressing that point. It's a theme that's come up in every single talk so far, including Professor Livingston, and I'm of course very grateful to yesterday's speakers also. We will of course focus on this much more in the next session, which will come in 1 hour. And this will be a theme, I think, that we will highlight in the special issue that Professor Chung has very kindly offered to help us promote in the American Journal of Alzheimer's Disease. So please do look out for that. So without further ado, and because it's lunchtime, I think we should probably finish up. And again, thank Stefano and all the
Thank
team
you.
for the
Very
insights.
nice to see you.
Yes.
Thank you.
And
Bye.
hope to see you again very soon. Bye-bye.
Bye-bye. Bye-bye. Thank you.
Bye. Bye.